Good morning, and thank you so much for creating time for us. It is Wednesday, and you know by now, each and every Wednesday, it is time we have dedicated on the program to just sort of like learn about our health and our lifestyle to be able to be better beings in the society. They say that a healthier nation is a wealthier nation. Actually, this platform is one that helps us do exactly that, to take better care of ourselves and to be able to understand different conditions and how to manage them. And that is what we have been doing here. And today we continue with that momentum. And I'm hosting this particular morning a very interesting professional. And we are going to be delving into the world of children as we talk about migraines in children. Ever wondered if you're a parent or a caregiver, your child constantly telling you anaumwa na kichwa, headaches here, there, and it's something that keeps recurring and you're wondering where it's coming from. Some children don't even know how to say it when they're having headaches. You know, the way children, when they're sick, they don't know what's happening in their system. So it's really hard to pick that a child is going through migraines or headaches. So today we want to talk about the telltale signs, how to manage, what are the causes, and of course the non-medical and the medical approaches to, you know, just managing migraines when it comes to children. I'll be talking to Dr. Yvonne Nyakeri. She's with me here in studio. She's a consultant pediatric neurologist. Karibu sana to the program.
Asante sana.
Right. So I normally don't usually do this, but somebody recently suggested that when you're hosting these doctors, Safin, please start by asking them what their day job looks like. Because sometimes we go to the hospital, we are referred, we are told, go see a psychologist, go see a physiotherapist, go see oncologist. So you wonder, what's the difference? All we know is daktari. So nikasema, I'll be trying. So pediatric neurologist, tell us a bit about Dr. Nyakeri and what she does on a regular basis.
Okay. Thank you for that. It's very dynamic. It's very different each day. But some of the things that we need to accomplish is that when we wake up in the morning, we do have our clients, our children who are in the wards. So we would start with seeing the ones in the inpatient in the hospitals. And then later on, we will settle down to going to clinic, or if we have any teaching activities, we plan for that during the day. Yes.
All right, so that is what she does on a regular basis. So today she's here in her capacity as a doctor and also to communicate to us about how to manage migraines in children, and probably just to begin by the very basic, explaining to us how common this condition is and what it is exactly. And also I was curious to know what's the main difference between migraines and the kawaida headache.
Yes.
Because usually that's usually a very tricky one.
I mean, headaches is one of a common symptom that brings people to the hospital, to the emergency department, to our clinics. So it's a very common symptom up there. And there are many different reasons why people have headaches. I mean, for our children, the most common reason is potentially they have an infection, our common colds. They can present also with headaches, and that will be one of the complaints. So when we talk about headaches, there are many different types of headaches. And then we try to distinguish what type of headache it is, why is it there, what is the cause. Then we try to figure out how to best manage somebody. So migraine is a type of a headache. It is, in the scheme of, it's the commonest type of headaches. When we are talking about headaches, we try to divide them into two. Primary headaches and secondary headaches. So primary headaches just means that somebody is prone to headaches, no reason why. And then secondary headaches are the ones which are brought on by something. And that's when now we talk about the infection. If somebody has been hit on the head, then you get headaches. You would have a concussion. If you have the bad things like meningitis, if you had a tumor, then you'd present with headaches. But then we'd call that secondary headaches. We look for that, and then we try to manage appropriately. So secondary headaches are not as common as primary headaches. Primary headaches like migraines, another one we call it tension type headaches, another one we call cluster headaches, and so on. So in this instance, because we can talk for a full day and for a full week about different types of headaches, then we narrowed it down to
so we
migraines.
chose to talk about migraines.
Yes.
So you've touched on very fundamental causes, and one thing I've caught is even hitting of the head and all that. So I want us to put this in the context of children. You understand their day-to-day activities and what they do on a regular basis. I mean, you probably also need to shed some light on, you know, what are some of the things that would trigger, you know, migraines when it comes to children. Of course, we are talking about migraines in children because it's something that, like Daktari is telling me this morning, is very common, especially when it comes to the types of headaches. This is ranked among the primary, you know, types of headaches. And of course, that is what we want to really delve into. And of course, you know, like I told you when we were starting the program, there are medical and non-medical strategies of managing migraines, and that's why with me in studio I'll be hosting two ladies. So Dr. Yvonne Nyakeri has been with us, and now joining us is Anne-Mwari Muthaura. She's a clinical psychologist. Now her part is the non-medical one. Karibu sana.
Asante sana.
Yeah? Good to see you, good to have you.
Thank you for having me.
Yeah. All right, so I'll start from where I started, and then I'll pick up, we put a comma on what we're talking about. So let me also just get to hear from you. When we started the program, I told Dr. Nyakeri that people have been telling me, Safin, when you bring these professionals, kindly ask them what their day-to-day job is, because sometimes we go to the hospital, we are referred, we are told, go to an oncologist, go to a pediatrician, go to a nutritionist. You don't know why you've been sent there. So I said I'll try. Every time I bring in a different cadre of a medic, I'll be asking them what their day job looks like, so that in the event you're told, go see a clinical psychologist, yes. You know why you've been referred there. So tell me a bit about yourself.
All right. My name is Mwari Muthaura. I'm a consultant clinical psychologist. So my day-to-day looks like working with people who are struggling with daily adjustments in life, whether they have mental health illnesses, need assessments, evaluations, treatments to help them cope with mental health problems. You don't necessarily have to be sick, actually. Sometimes people have physical illness and are not responding well to treatment because there are psychological factors affecting them. So my job is to help them go through that, learn how to manage it while working alongside doctors. Yes.
It's good that we have you this morning, because you're going to demystify a myth that once you're told, go see a psychologist, hey, mambo imechemka. You know, things have just gone haywire.
Yes.
So we want to understand how you come in managing migraines in children. But I wanted you to respond to the most common risk triggers in the world of children that trigger migraines.
Right. So I'd probably start with there are people who are just prone to migraines. Okay, and then there are people who have never even experienced a headache in their life. So when we talk about you're prone to migraines, you probably have a family history, a strong family history of migraines or any other type of headaches. And then you get the triggers that make you have a migraine attack. So common triggers, I usually want to start very basic, something like dehydration. You're not taking enough water. That can trigger a migraine to somebody who's prone to migraines. Not having your regular meals, so you get low blood glucose, then you can get a trigger. Very important thing is sleep. You know, everybody, children, adolescents, adults, we have our required sleep duration times. So when you don't sleep enough, when you're having interrupted sleep, then you have sleep deprivation. That's a very strong trigger for migraines.
What's like the minimum hours recommended for children?
Right. So it depends in different age groups. I would say children, preschool children, at least if you're having 15 hours of sleep, and that is broken down in terms of 12 hours at night, and then you have 2 naps during the day. I would put that in the lower category, at least age 3. By the time you're going to school, you're in PP1, PP2, you're probably not napping during the day, but you should have at least 12 hours of sleep. As you get into the older age bracket, the older children, age 10, age 12, 9 hours 10 hours of sleep is recommended. Adolescents, we recommend at least 8 to 9 hours. We know that a lot of them do not get that, and that's another whole different discussion.
There's a lot of screen time,
exactly,
that age bracket that denies them the sleep that they need.
Yes. And for us adults, we do say around 7-8 hours of sleep. And some people can do for shorter durations, and potentially if they're not prone to migraines, then they'll not know that they need more sleep. Yes.
All right. So sleep is one of them. Mware, probably just tell me a bit about some of the causes that are not like directly physical or related to things like sleep and all that, because you deal mostly with the mind. Take me to the mind of a child and what you think are some of the triggers that can make a child have migraines from a psychological point of view.
All right. So specifically in this day and age where there's so much pressure, so much exposure to a lot of things our children have today that we didn't have back in our day. So there's a lot of stress, more pressure. We're seeing like children go to school earlier now when I'm out at 4:30 a.m. and longer. So I'd be out at 4 a.m. I can see kids being picked, kids as little as 5. And then later on in the day, when you're going back home past 6:30, you see the same bus dropping the same kids. So let's say longer days, stress. I would also talk about tensions that are happening around us. So if there's family tension or tension at home, parents not getting along, bullying in school. Sometimes we have conversion disorder. So a child will come and say, Daktari here, but then Daktari cannot find a cause. The child is having seizures, they're fainting, they cannot see, they have memory problems, things like that that would need a pediatric neurologist. But then the more they investigate, they cannot find what's happening. So most times we'll diagnose a child with conversion disorder. It's a psychosomatic illness. And so we have to find the root cause and figure out how to manage that. And sometimes it's really things that are avoidable or that can be adjusted, changing environment, changing school, figuring out what's going at home, and so on and so forth. So there's a lot of mental strain that goes into that. So for some people, medication without actually intervening in the environment might not be helpful at all. No.
Yeah. Yes. So no wonder now you both need to work as a team, because what I'm getting is that some triggers may not be picked by a neurologist, for instance. You have to refer to a psychologist to be able to pick it up and help. All right. So before we get there, Dr. Nyakeri, probably just tell us a bit about, children. It depends on the age though, but most of the children do not know what usually happens in their system, because they're also growing and trying to understand themselves. So it's usually hard to pick when, like a specific issue, when a child is presenting with migraines. So as a parent or a caregiver, how do you advise we pick it up? Like how does a child with migraines behave, so that we can be able to tell whether this is what this is exactly?
So I would say that different ages, different presentations in terms of even how the migraine may present itself and how you're able to communicate your problems or your symptoms. And there's also something that we call migraine variants. There are short episodes in somebody's life where they tell us that these are sort of like somebody who's prone to migraines. We call them precursors to migraines. And if I can start that from the early age, we do have infants. We call that infantile colic. So I'm not saying that colic is a precursor to, you'll have migraines in future, but there's children who have colic, and then later on they have migraines. And how you know that is that when we diagnose migraine later on, when you're in at least the older age group, and then you look back into your life, and then you say, how was this child? Was this a colicky child? At around age 4 to 7, there's another episodic syndrome, so period where somebody may have what we call cyclic vomiting syndrome. So what happens in such a situation is that a child is complaining about abdominal pain, is having episodes of vomiting, very severe nausea. And it comes, it goes, okay? And once it comes, it's very severe such that somebody ends up in the emergency department. We investigate and see why is somebody having this vomiting and abdominal episode.
And it has to be like something that happens.
It happens
in repeated
patterns. Yeah, and then typically we would say, okay, maybe it's gastritis. Then we send over to our colleagues who are pediatric gastroenterologists. We do have also a type of seizure that presents with such episodes of vomiting. So when we are looking at such children with such symptoms, we have to think broadly. And when we talk about cyclic vomiting syndrome, we can identify it at that time. And sometimes later on, we may say, actually, you are having cyclic vomiting syndrome at some point. We have what we call abdominal migraines, where you're just having abdominal pain, still in migraines,
That's
still
unique.
happening in periods. And then I've had instances where a child, as soon as he learned how to express himself, he would hit his head. And as soon as a word came out, he was like, head, okay? And then later on, he says, ouchie, okay? So it's something that it may not be instantaneous. It's something that we get to learn over time. And even as you get older, we usually say females, especially adolescents, during that preteen, teen age when your hormones are trying to peak in the pubertal stage. That's a very good time to have migraines for people who are prone to migraines. And then later on in adult life, you know, what we've talked about in terms of our stressors, we are able to identify stressors even in the young children. Yeah, and then once we've identified stressors, then that's when we do, like now, the multidisciplinary team where we have to make sure the child's quality of life is improved.
Is improving.
Yeah.
How common is it, migraines in children? Usually sometimes we try and deal with the numbers to see how big a problem we are discussing.
Right. So if different situations, different areas have different presentations. So roughly, we would say about 10%. There's a colleague of mine who did a study in primary school children here in Nairobi, whereby about 10% of children had reported headaches. That is about 1 in 10 children. And out of the 10%, about half of them had migraines. Yes, so it's
quite common.
It's quite common.
All right. Marie, they usually say that, you know, children are not stressed. Why would they be stressed? I mean, for what reason, you know? So are children prone to stress, and where does this stress come from?
Yes, children are prone to stress. I think to be human is just to be prone to stress as it is, because we sense things around us, so not just mentally. There are people who, as Dr. will tell you, have sensory overload. So stress not necessarily being the mental thing, it could be dislikes. For a lot of people, it could be noise, it could be tactile, like touch sensations, it could be anything. So stress is not necessarily this for a lot of people. But yes, if we're talking about mental stress, definitely children have stress because I think of all the populations in humanity, children have lower filters. They likely experience things exactly as they're happening and don't have time to have nuance or pick apart things. So they'll pick tone, they'll pick energy, right? So anything really in the environment will give them stress. But yes, children have stress. There's a lot of things going on social media. So where we learn to compare ourselves with other people when we are really young, and now everybody has one of these gadgets. So you see where people are living, what they're wearing, what they say they do with their weekends. People come and tell you what their family life looks like, and you start to compare a lot of things. That's also the beginning of stress for a lot of children. Or now family structures look different. Some homes have a mommy and a daddy. Others have just a mommy or just a daddy. Others have 2 mummies, 2 daddies. Like family environments are different. And as children move around the world, you know, at home, they don't know anything is different. But as they move around in the world, let's say in school, in church, in other communities, they start to realize the differences. And that also introduces a lot of stress in their life because, of course, there's a lot of questioning and judgment and wanting to understand why they're not like other people. Performance right now is also a big thing where you tell children they have to get this grade, then they have to go to this school, or they need to get into these programs. Some children don't have a breather. They're in school from 5 to 5, then extracurricular activities. And then on Saturday, they're in a football league. And then in the afternoon, they're in a music class. In the evening, martial arts. At night, some other thing. They're playing in a concert. Children don't have breathers. And things we also can do as adults, we are making children do that now. So they don't have time to sleep or breathe. And then once it's evening...
Basically, they don't have time to be children.
Exactly. And then their body changes that are taking place. By the time a child is hitting 8, 9, and now puberty seems to be starting a little earlier, hormonal changes, body changes, just a lot of confusion, sexual identity, sexual awareness. There's so much going on, and that would be the introduction of stress in a lot of people's lives.
Yeah, and stress is one of the triggers of migraines. That's why I asked that question, so that you understand the world of a child and where this could be coming from. Because usually the first suspicion a parent or a caregiver would have is that the child is sick physically, you know. But it could be any other thing around the environment of this particular child. I don't know whether this will fall in your docket or Dr. Nyakeri. Sometimes you find a child finding the noise around them too loud, or light is too bright, or you know, compared to their peers. I don't know how you would explain that. You know.
Maybe I can start. So in terms of now the typical migraine symptoms that somebody experiences, more so for children, it could be you're just having pain at the front or pain on the sides. As you get older, it may just rest on one side, and that's what adults we know as typical migraines. And then the pain is typically like a throbbing pain, so you feel like you're being hammered. And then it may come also now with the light sensitivity and then noise sensitivity, such that some of the things you want to do is withdraw. I withdraw from all these lights, I withdraw from all this noise, so that the symptoms can calm down. Because typically you have a bit of higher intensity of pain. Some people now may talk about, I'm feeling dizzy, I'm feeling what I'm seeing, and that touches to migraines. You can have it with a warning, or you can have it without a warning. And when we talk about warning, we're talking about aura. And some people, a lot of people may have light as an aura, like a visual aura. So I may not see anything. I may see like a blind spot. I may see flashing lights as I'm looking directly like this. I may see some wavy lines just passing through my how I'm seeing. And then I know that normally when this happens, I know my headache is coming. Okay? Some people may actually experience some tingling sensation in the face or the hand. Some people may just experience now the dizziness. Some people may experience weakness, and it may present actually like I'm getting what we call a stroke. But then I get it and then I recover. So I know it's not a stroke. And in such instances, for us as health providers, we needed to have really made sure that in terms of our investigations, which is something we can talk about later, just to make sure that it's not a stroke, it's not an impending stroke, it's just how your migraines present. So different people have different presentations. Yeah.
All right. So let's talk about management. And like I said, we're going to be talking about both medical and the non-medical. So usually the first line of defense is usually the medical, because that's where most parents rush to. So I'll start with you, Dr. Nyakeri, still. So when a parent or a caregiver has come with their child, or what's like, let's start here, what's like the best time to know that now this one requires medical attention? Because we, all mothers are doctors.
Yes.
And we will try to deal with that thing until, you know, so advise a parent or a caregiver, at what point do you really need to take it up and take it seriously to go to the hospital? And then what happens like when they come? So what do you do? What are the procedures like?
Right. I would start by saying that headache is a very, it's a personal experience. In terms of, if I tell you now I have a very severe headache, okay, it is my experience that you cannot refute.
Yeah.
Then it comes to where children report to their parents that they're having headaches. And then a parent would ask, how would this child know that he's having a headache? Like, is that something that they would know?
Yeah, go sleep.
Yes,
drink water.
That is the usual first line defense of parents. And it's as wide as I probably feel like my child is trying to not go to school today.
Exactly.
So drink water and go to school. So it's a personal experience that unfortunately it's misunderstood. It's underdiagnosed just because of such situations. So in terms of when do we tell a parent to bring the child to the hospital, that is based on you knowing your child and you listening to your child. I usually like to say that we need to listen to our children as young as they are and try to explore, like, yes, you've told me something is happening. I need to figure out the degree and everything before I go to the hospital. If you're not comfortable for whatever reason, we go to the hospital. We explore with the health provider who's there and try to understand, are there any red flags? So when you come to us, we ask ourselves, are there any red flags? Are there any danger signs? And I usually also talk to my young clients just for them to give me their personal experience as opposed to what mommy sees the child is having, so that we get more information. And actually, a lot of times, parents come like, oh, I didn't even know that, yeah? So I would say that that will be based on your judgment as a parent to come to the hospital. Definitely if somebody is sick, is having not just a headache, other symptoms, I know that they'll be in the hospital at that time. When they come to the hospital, the main thing where we have to take the history. And as we're taking the history, I've said we're looking at the danger signs. What it's telling us, is it the secondary headaches? Is it an infection? Did you get trauma to the head? Do you have another common one is sinusitis? And then we treat based on that. If we identify that, yes, you're having a primary headache or you're having migraine, then number one, the most important thing is to discuss with the family and the child what is a migraine for them to understand. If we're talking about the ones with the aura, meaning you're having some differences or something is happening with your body, you really need to understand that it is migraine with aura, not you're not having a stroke or anything. We examine you, looking for all those danger signs. Do we need to admit you? Do we need to do further tests? Further tests like for meningitis. I want to do a lumbar puncture to rule out meningitis. I want to do imaging. Do I do a CT scan? Do I do an MRI? So that is all a discussion with the family based on what we are seeing. To rule out based on what we are seeing. So not everybody gets a lumbar puncture, not everybody gets imaging done. If it is a classic, typical migraine, then we discuss about that. And the family and us, we have to be properly on board. We explore the stressors before we think about referring to our colleagues in clinical psychology. And we see, okay, is this something that we need to partner with them? Or are there no potential stressors? As we are walking the journey, because now if you come to the emergency department, we'll see you in clinic, and then we continue making sure that we follow up. Is it something that has completely gone and then it comes later? Why? Because we have people who have what we call chronic migraines. More than half the month they're having headaches. And then we have a different strategy for them, and that is both medical and non-medical.
All right. When it gets to a point, we still have a lot that we will explore with what you do.
Yeah.
But let me cross over to you, Mwari, for a bit. So when it comes to a point where you've identified that it's not a medical issue, the child has been referred to your institution or to your office, for instance. So what do you do to pick out, whatever stressors or triggers that could be? And then how do you begin to navigate that journey with the parent and the child?
Yeah, and most times also, Daktari will not just send them because it's also non-medical. It might be that they are chronic migraine sufferers and it's incapacitating their life. So if your quality of life is also low,
then you come in.
Yes, because dealing with a chronic illness is also stressful. And if you have school to go through, you have life to go through, and it is rendering you incapacitated, then also you will need help with that. So it's both. I mean, whether you're on medicine or not, it's still an intervention to take. So some of the things we do is, for example, teaching these children how to use their bodies, their minds, to ease their bodies, right? So for a lot of children and adults, but let's say children, Daktari was talking about having the aura, and you realize that only the child can report that to you.
Yeah.
And sometimes children will walk around saying, I'm smelling cigarettes. That's a common symptom for a lot, or they're having a smell that nobody else can smell. There are things they'll say that you will learn to know, okay, my child is about to have a migraine again. So one of the things I do is teach the parents how to listen to their children, but also listen with empathy. Because most times the child will be like, I'm smelling something. And then the mother will be like, get off that screen quickly, that headache. Your screen is causing the headache, right?
You're playing too much in the sun.
Exactly.
Yeah.
So you're the first point of intervention as a parent is learning how to listen to the child.
Yeah.
And so for that, we would do parent-child interactive therapy, where you learn to communicate with your child or also to listen to their nonverbal cues or their body language. Most times, parents are caught unawares by the seizures or by whatever other symptoms, vomiting and all that. Yet, if you really ask them, they'll tell you, 10 minutes before then, the child had done this or said this or was starting to sound disoriented. So because the parent is the first point of intervention, I'd like to first train that parent to learn to listen to their child and talk a lot about it.
Yeah. As you train the parent, how do you separate the negative perception that is usually, attached to, you've been told to go see a psychologist, then your child has been telling you interesting things about smelling things you can't smell, feeling things you can't feel. So as a parent, you're already on your you're like, what's happening with my child? And then you're told, go see a psychologist. You're like, okay, so what's happening? How do you separate that and remove that negative perception that is usually...
I was actually headed there with the issue of biofeedback, but let me answer that. There has been a lot of stigma attached to the issue of psychiatric intervention, psychological intervention. You're told to see a neuropsychologist or a neuropsychiatrist, and the moment you hear psych,
you're like,
you're like, now they say we are mad, now they think we're...
Now you're saying my child...
You've heard of that, actually, right? Yes, or something is wrong with us.
What did you see for you to send me to psychiatry or psychology?
Exactly. And sometimes, yes, and sometimes the doctor might be very specific in first sending the parent to the psychologist or psychiatrist, and they think you're judging them. But no, I applaud. I mean, a lot has been done in the recent years where we have gone out of our way to destigmatize the issue of mental health, right? And to let people know that simply because, it's invisible, we think the moment mental health gets mentioned, that's something rather ridiculous, and why would you say that about us, right? But if you learn to look at a lot of the things that affect your mental health as something also physical, right? Because there is an organ that's either malfunctioning or a part of your body that's malfunctioning. That becomes easier. The same way she'll be treating a body part is the same way we're doing with our treatments as well, right? But we also need to know that a lot of treatment is highly collaborative. She won't just send you to me, or I won't just send you to her. I will also send you to an occupational therapist, to a physiotherapist, to, I might even ask you to actually consider something that allows you to move your body. So in every treatment, for it to be successful, a lot of disciplines have to come to place, because we're not just treating your hand or your head, or it's the whole person. And if you look at it holistically, then psychiatry and psychology needn't be an issue. It's really just physical treatment like every other, right? And so when I was talking about the parent learning to listen to their child, a lot of the things we'd like to emphasize on would be something like empathy. Learning to listen to your child with a lot of empathy, because eventually children learn to know what you don't approve of and what you approve of, and they stop talking to you. And if your child can't come to you with the slightest thing like, I am smelling cigarettes.
So where do you want them to go?
Exactly.
Who do you want them to talk to?
They will go to school that day, and you will be called to go pick them. Or something else could happen that might be endangering to that child. So listening and responding with empathy. So if it's a screen, if it's a TV, before you snap, you can always learn how to humanize your language and soften it a little bit. So if your child is telling you they're having the symptoms again, and you've also been told by Dr. here, some of the things to consider are also not just medical, for example, sleep, screen time.
Or even what's happening in your family breakdown, you know. You guys are having issues and it's affecting the child.
Yes, softening that language and saying, do you think we could probably do without the screen time and do something else? We can do it together. For the next 2 hours, or how about it? We sit down. Let's go outside and sit down and talk about what's going on. Befriend your child so that your child doesn't have to look outside for help or sit in silence and suffer without your help, right? And even as we teach children how to cope, so for example, some of the things would be, so biofeedback is teaching your mind to control your body. Right? And turning those invisible things into something physical. So teaching your child to listen to their sensations. So is it skin irritation, as she mentioned, or is it the smell, whatever aura you're getting?
Or whatever.
Exactly. Learning to visualize that and knowing how to soothe your body now that you know it. So listening, that listening I'm talking about is listening to your body, which we're also teaching parents to listen to their child's body, is teaching your mind actually to just soothe your body, right? So what do we do then when we start having the tension or the itchy feet or whatever? What is the next course of action, right? And how do I soothe myself? And is that pain? We also have things like somatic experiencing, right? Where you're teaching yourself to translate that into something physical and then know how to ease it. And some of the things we would do would be progressive muscle relaxation, where you release tension to ease pain in your body. And sometimes, I mean, if you come to my office, you'll see people lying down on yoga mats, creating tension, releasing it, and it's just slowly teaching you how to soothe your body. If you cannot sleep because of pain, if you're unable to breathe because of pain, if you're unable to just function, what are some of the things you can do to dissipate the amount of distress you're going through, so that you can feel a bit easy and lighter? Because with a lot of people, actually, you just need to get through the first hurdle, and then everything starts to become easier. So in the morning, are you feeling incapacitated because of that headache? What next? Is it something we can work on here? Do we have to go to hospital? If it's something we can work on here, we begin with that first step and train you to do what the body doesn't want to do, so that you're able to progress to the next step of the day. Shower, eat, and so on and so forth.
I'll come back to you just so you can add more on, the coping mechanisms. But let me go back to you, Dr. Also just share with me, So in terms of treatment, in terms of, you've already identified something you can deal with, you don't have to refer the patient. So what do you do? Is there like medication and how long and how do you do it?
Right.
Yeah.
So if somebody presents now with a headache, the main thing we want to do is dull down that headache, make it go away. And something simple that we do at home is giving you paracetamol, giving you ibuprofen, brufen.
Yeah.
And we see what works, okay? If it needs escalation, meaning you've gone to the hospital because of that, then there's things that we do like hydration, and we can give some IV painkillers and so on. So this is what we call managing the headache now. And we recommend you give the painkillers as early as the headache is starting. You don't wait for it to escalate.
Yeah, to get worse.
Because then once it's escalated, de-escalating it is a problem. And then you may be having the prominent nausea, vomiting. You may need some anti-vomiting medicines. So the thing with migraines, it's something that keeps on recurring. And as it recurs, you get to know and understand your child better and better. We recommend keeping what we call a headache diary. Headache diary means that at this time, what happened, what time, what do I think triggered this headache? As you keep the headache diary, you're identifying what are my triggers, such that how do I control and prevent more of the headaches. So once it has happened, you de-escalate it in that manner. Then when we are reviewing in the hospital setting, how frequent are you having headaches? Is it infrequent? Once in a month, twice in a month? That is not a frequent headache. Then we look for what is the best strategy. What works for you well? Is it paracetamol? Does that make it go away? Is it brufen? Do I need to start on brufen before I give paracetamol? Do those two not work? Then we figure out what is the next step.
So does that mean then that this child will be on medication for the rest of their lives?
Right.
Or does it get to a point where it can completely go away?
So we do have periods where you have an escalation in your headaches. And that's why we are trying to identify what are your triggers so that you work on your triggers. And then we work on it at that point, and then they go away. When we talk about chronic migraines, meaning you're having more than half the month, you're having headaches, then we have what we call preventative strategies to reduce those headache days down to more than half of what you're getting and even lower. From experience of people who have migraines, a lot of people just have periods in time where it escalates and it de-escalates. So like if you get an infection, you may get a headache at that point. Once the infection has gone, everything has gone down. If I'm having a stressful situation at this point in time, I know that once the stress is over, it will go down.
All right.
So we pray that it's not a long-term period. But then we have the preventative medicines, which we take for about 3 months on a daily basis to reduce the headaches and potentially make you get out of that period of chronic migraine for it to be once in a while. All
right. I want to work with the few minutes that I have to just wind this down, but just Mari, if you were to shed just a bit, maybe a minute, just add on the coping mechanisms, especially when it is the environment of the child that is causing the migraines, maybe the family issues. How do you work with this whole community to ensure that you create a safer environment for this child to better manage the migraines as we bring this to a close? Okay.
We work with all the adults in their life, right? So,
or it's school, family or it's whatever.
Yes. Yeah. So we do family therapy, individual therapy, but definitely family therapy, or support groups even for kids and teens going through issues like this. So it's basically working on your life, unpacking a lot of the struggles that you're going through and learning to cope with them in an effort to dissipate the pain physically, right? So also, even in school, we do advise teachers, we'll write reports, we'll have conference calls with them, just to teach them how to manage the child and manage the environment of the child. Like the child is having a hard day, they've been given medication, they have a diagnosis, and so on and so forth. We just teach them how to manage the environment for the child. But the bottom line is, whatever you do as a caregiver, as a teacher, as a doctor, as a therapist, we're trying to give this child autonomy over their health.
Yeah.
So making them feel that they're in control of this, they can report, be believed, and get help, but that they can also do something to help themselves.
About
yes.
it. All right, thank you so much for your time. 30 seconds for your parting shot. Talk to a parent or a caregiver on why they should address this as soon as yesterday. How does it affect the life, the overall well-being of a child and their life, and what they can do? Let me start with you, Dr. Nyakeri.
Okay. So headaches are a personal experience, and we know that it affects quality of life. It affects how we feel about ourselves. It affects school attendance, and we need to, there are strategies and there are ways in which that we can improve our child's quality of life, and that really should be taken in account by families.
Mari?
I think the best thing you can do for children and teenagers and young adults is learning to acknowledge their pain. So whatever they say, whether they think it, or you think it's not real or it's exaggerated, learn to believe their pain. I do think that that's the first step anyway, and then pace yourselves together. Do not let this go out of control, and don't let it also control your lives. So any step you can do, you know, within reason, to improve the quality of your child's life, go for that, because the child, again, is the heart of the family. And when that life is not okay, the rest of the family dissipates into chaos. Yes,
it is true. That's very true. When a child is not okay, the whole family is not okay. So let's try and make the childhood bearable for children. Let's allow children to be children and to enjoy their lives to the fullest, wherever this could be coming from within them or from the community around them or from school. Let's find out what are the triggers and assist these children to live healthier and better lives. I've been talking about migraines in children. Maybe in future we should talk about stress and depression when it comes to children. You never know. Keep it right here on health and lifestyle. Mwari Mudaura is a clinical psychologist. I've also been having a sit down with Dr. Yvonne Nyakeri, consultant pediatric neurologist, as we were talking about migraines in children. We really appreciate your time and company as well. Thank you so much. Do join us next week. Another episode, another discussion. My name is Safina Cheng Oma. Until there, it's a wrap. Have a lovely day ahead and keep watching Citizen Television.